So there will be an enzyme in which this drug will inhibit. Okay, SGL2 inhibitor acts in the kidney. Okay, this is the new drug that has been approved by FDA. Okay, so when approved by FDA, so you got to know all of them. Okay, ini group of drugs. Example of each of the group pun banyak. Okay, ini group sahaja. So saya introduce the groups first. And in this figure, you can see that ini saya ambil daripada Google. Okay, so sulfonylurea, maglitanides, incretin will act to increase insulin secretion. Okay, the action on GI tract is incretins, alpha glucosidase inhibitor, amylin. Okay. This is another type of adjuvant therapy acting similar like insulin. Okay, acts on the GI, and then metformin anti-exolidindiones will act on the liver. Thiazolidindiones will act on the fat cells. Okay, okay, so kamu boleh tengok dekat sini. So, all of this action will act during hyperglycemic condition. So that actually summarizes everything. So we'll go on each of the group. We will start with oral hypoglycemic drugs. The first one is sulfonylurea. Okay, so sulfonylurea is an old drug. They have first generation and second generation. So the difference between these two drugs is in terms of pharmacokinetics. So please compare in terms of pharmacokinetics. So nowadays, the latest addition is the second generation, but the first generation are still available in the usage. Okay, in clinical usage, tapi tak banyak sebab dia old drugs. Okay, so the generation of sulfonylurea can be divided ataupun can be distinguished in terms of pharmacokinetics, which is duration of action, activity of the metabolites of the drugs, elimination of the drugs, structure tak payah tahu. Okay, well, it's on there sebab dia dah memang ada dekat sini. Saya tak modify. Okay, and why you are comparing it? Because sulfonylurea is like the old drug, the first drug, and the drugs that is being used initially to treat diabetic conditions. Okay, tapi why it is so special? Because it's still there, and the old drug is being modified into the new generation, and it is ada difference lah. Okay, so the difference is kalau the old drugs, kalau you tengok balik the first generation, the dosage is actually very high dosage in order to for the drugs to be able to show the action. Okay, tapi the new generation, the dosage is a little bit lower compared to the old generation. So why is this important? Okay, sebab sulfonylurea dia act atas beta cells yang masih function. So when it acts on beta cells yang masih function to actually release insulin, a lot of insulin being produced in a long duration of action, it will actually contribute to hypoglycemia. Okay, so kalau dalam keadaan hyperglycemia, it's good. Tapi kalau the dosage is high, the duration of action long, so your patient is actually exposed to the risk of hypoglycemia. So sulfonylurea, kalau kita tanya adverse effect, kita kata hypoglycemia lah. Okay, so we have the new generation, which is the second generation. So you can see that the dosage is actually being reduced more than 10 times lower, and the duration of action is some is short, some is intermediate, okay, and the metabolites is inactive, and elimination is good, okay, 65 to 80% is being eliminated. Okay, so other than elimination and effect of sulfonylurea, okay, this drug is also highly bound to plasma protein. So when a highly bound drug with such action, it has the chances of interact with other protein bound drug. So drug-drug interaction is at risk with sulfonylurea. Okay, so most of the first generation is being modified into second generation and modified into smaller size, control release or modified release. Okay, so why we want to reduce the risk of hypoglycemia due to the character of sulfonylurea. Okay, so you can compare these two generations in terms of differences in half-lives, difference in the route of metabolism, excretion, and also receptor binding. Okay, so I have also indicated that tolbutamide from the first generation is the most well tolerated for the old sulfonylurea. It has the mildest effect, and the clopropamide with the 2-star rarely used. Why? Because the half-life is about 36 hours and it will give hypoglycemic side effects of the first generation. Okay, so most of the sulfonylurea nowadays is glipizide, glycoside, glimepiride, okay, glibenclamide or glyburide. Okay, so you can see from here, nanti you boleh tambah you punya bacaan. Okay, about pharmacokinetics and to compare between the two groups of sulfonylurea. And mechanism of action of sulfonylurea is that it acts directly on beta cells of the islets of Langerhans to stimulate insulin release and forms a transmembrane complex with ATP sensitive potassium channel. Okay, and there will be an influx of calcium in the cells, activates calcium dependent signaling proteins which cause the exocytosis of insulin. So sama macam physiological process of insulin release. Okay, so you boleh tengok this figure as well. So this drug can be used as monotherapy or combination therapy. Okay, so the addition of the two will actually increase the risk of hypoglycemia, but meaning when you prescribe to patient of two combinations of drugs, then meaning that you have to monitor the patient closely. Okay, so the drugs can be combined with any oral hypoglycemic drugs which does not have similar action as sulfonylurea. Okay, and the action of sulfonylurea is actually dependent on the function of beta cells, and this drug can be used as an alternative first-line therapy if metformin is not effective. Okay, so why did I say that? It's because when a patient is being diagnosed as having diabetes mellitus, the first line of therapy is metformin. Okay, bukan sulfonylurea. But in some patients, they don't respond well to metformin. Okay, so when they don't respond well, doctor will have an option to actually switch the drug to actually bring down the glucose level and then give sulfonylurea. Okay, now drug interaction. This is the most important. Sulfonylurea with corticosteroids, loss of glycemic control of sulfonylurea. So meaning patient there will be a high increase in glucose level in the blood. Okay, so loss of glycemic control of sulfonylurea. Okay, and then after that is interaction with drugs that will displace sulfonylurea from plasma protein. Drugs that will reduce metabolism, drugs that will reduce excretion of sulfonylurea, okay, and then drugs that will enhance the hypoglycemic activity of sulfonylurea. Okay. Now, number 2 is megliteinide analogs. Okay, these are the two examples, repaglinide and natiglinide, and their action is also dependent on functional beta cells. Okay, similar mechanism of action of sulfonylurea that cause exocytosis of insulin. Okay, but then they will actually bind to a different site on the sulfonylurea receptors. Okay, so their action is similar to sulfonylurea. Okay, so how does the scientist get repaglinide and natiglinide? Okay, silap. Okay, so you got sulfonylurea, glipizide, and then the addition with salicylate or salicylic acid derivative, then you got a different drugs. Okay, it's just for your interest. You don't have to remember. Okay, and megliteinide has a rapid onset, short duration of action of insulin release, effective as postprandial glucose regulator, effective as adjunct therapy, effective as combination therapy. Okay, so the drug is rapidly and well absorbed after taken orally, and it has to be taken 15 minutes before meal, metabolized by the liver, cytochrome P450. Okay, the hypoglycemic case is actually lower than sulfonylurea. Okay, sulfonylurea, the cases is actually higher. Okay, so this drug is very useful for the elderly. Okay, so but then it has effect on body weight. Okay, sulfonylurea and megliteinide has effect on body weight. There is a chance that increment of body weight. Okay, but megliteinide has a lesser chance of increasing. There will be some increase, but not as much as sulfonylurea. Okay. So when they increase in insulin level, the body will retain glucose, excrete less glucose, so they retain more calories, so there is a chance of increasing of body weight. Okay? So drug-drug interaction, similar to sulfonylurea. Okay? Most of them is our concern with hypoglycemic or hyperglycemic chances. Okay? So monoamine oxidase inhibitors, non-selective beta blockers, NSAIDs, I think you boleh baca sendirilah. Okay? And you boleh baca sendiri, tengok on drug-drug interaction. Okay? So that's all about the two drugs that act directly on pancreas, beta cell, and release insulin. Okay? So now we move on to the drugs that will sensitize insulin receptors on the muscle. Okay? So for this group, you are very lucky. Biguanides that sensitize insulin receptor, biguanides ada satu saja, ada metformin saja. So jangan silap. Okay? And what is so special about metformin? Metformin is the drug used as the first line of treatment to those who are diagnosed, in the first diagnosis of diabetes mellitus. Okay? So it acts on insulin receptors. So insulin sensitizer, reduce insulin resistance, decrease blood glucose by decreasing hepatic glucose production. So these are all the outcome on how it sensitizes insulin. Okay, all of these are the metabolic effect on how it sensitizes insulin. So how does metformin act? It activates AMP activated protein kinase. So what is AMPK? AMPK. Okay, AMP activated protein kinase. It is an enzyme in the liver which is very important for insulin signaling. Okay, so it metabolizes the glucose and fat when the AMPK is activated. Okay, improves insulin sensitivity via AMPK signaling in skeletal muscle and activates the opening of GLUT4 in plasma membrane, enhance insulin stimulated glucose uptake in skeletal muscle by increasing translocation of GLUT4, okay, and results in glucose uptake. So these are the mechanism of insulin sensitizer. At the same time, it has a role in inhibiting fatty acid synthesis, okay. So, tapi I'm looking for this, for the action of metformin. Okay? So, metformin is recommended to those who are early diagnosed, first line of treatment. It can be used alone or combination. And this drug has a low risk of hypoglycemia. Okay? Rapidly but incompletely absorbed, has little binding on protein serum or plasma protein, and not interfering with co-administered drug. it's not being metabolized as well. So the metformin that is being taken in, it will be excreted as metformin as well. Okay? So this drug is very useful. Okay? Improve glucose uptake, suppress appetite, promotes weight reduction, and may be safely given to patients with mild to moderate renal impairment. This drug is also being used to those who are being identified as having pre-diabetic condition, and also it is also being given to those who are having pre-obese condition. Okay, but then there is a chance of reduction of vitamin B12 associated with metformin treatment. So periodic vitamin B12 should be considered and should be given to patient. Okay, so not being metabolized, excreted, unchanged, half-life is quite short. Okay, widely distributed, eliminated by the kidney. Okay, so boleh tengok, boleh baca balik. Adverse effect is transient. So drug interaction is less compared to sulfonylurea or other drugs that is being yang ada interaction with plasma protein. So interaction is less with metformin. But since this drug is actually eliminated via the kidney, there is a chance of drugs that can alter metformin elimination. Okay, so for example that I have there is cimetidine, procainamide, quinidine will compete with elimination of metformin. Okay, and then with organic cation transporter, there is also a chance of polymorphism of organic cation transporter. Okay, so organic cation transporter polymorphism will actually cause some difference in elimination of metformin. It is just baca saja. Okay, you don't have to. It's not that crucial yet. Okay, so maybe you can compare the uniqueness of metformin over sulfonylurea drugs. Okay, character of metformin and the character of sulfonylurea you can compare. Okay, so the second insulin sensitizer is an agonist to peroxisome proliferator receptor. Okay, PPAR gamma receptor. So the PPAR gamma will regulate genes that involves in the metabolism of glucose as well as fatty acid. Yeah. So these drugs are thiazolidinedione or glitazone group. Okay, pioglitazone or rosiglitazone. Okay. So it activates the PPAR gamma and sensitizes insulin. Okay. So you can tengok semula, okay, and compare. Okay, and the adverse effects of glitazones, hypoglycemia, it can cause hepatotoxicity, okay, and some of the glitazone has been withdrawn due to hepatotoxicity, and and some can actually worsen heart failure. Okay, can cause edema in patients with heart failure. Okay, so contraindicated in those patients. And there are also drug interactions, for example with oral contraceptions, in which glitazones can enhance the clearance of oral contraception. Okay, is that okay? Okay, the last three, they act on the GIT, alpha glucosidase inhibitor, peptidase 4 inhibitor, and incretin mimetics. So alpha glucosidase inhibitor, so meaning it will actually inhibit alpha glucosidase enzyme. Okay, so we have two examples here, which is A-carbos and B-glitol. So why is it important? Because the enzyme is responsible for the metabolism of carbohydrate to glucose in the small intestine. So the absorption of the glucose is delayed. Okay? So it will actually reduce the postprandial glucose level. So you must remember, this drug is not affecting beta cells in the pancreas, is not affecting insulin receptors, or not affecting insulin sensitivity. Okay, and this drug can be given as monotherapy or combination therapy. Okay, so A-carbos is poorly absorbed, metabolized by intestinal bacteria. So adverse effect is related to GIT. Okay, so not to be given to those who is having problem with GIT tract. Okay, now the incretin mimetics and DPP4 inhibitors, those two side of action, not similar side. Okay, so what are incretins? You have to know what are incretins. They are hormones that help to increase insulin production. The site is actually in the gut. It is only, the insulin is only being released when food is taken. Kalau you bagi injection, glucose injection, insulin ataupun incretins is not regulating insulin release. Okay, kalau ada intravenous glucose, plasma insulin is not being released unless it is being taken as food, okay, by mouth. Okay, so there are two types of incretin, which is glucagon-like peptide 1, glucose-dependent insulinotropic polypeptide. Okay, ini dalam badan, in the body. Okay, there are two types. Facilitate response of the pancreas and the liver to glucose fluctuation through their action on pancreatic beta cells and alpha cells. Okay, so that is how the incretin hormones act. But in type 2 diabetes mellitus, incretin level is actually low, so they cannot regulate insulin production. So that's why we have incretin mimetics. Okay, so the incretin mimetics are this: exenatide, LAR, liraglutide, semaglutide. Okay, ada a few. Okay, ada a few. So we have incretin genetics. So the role in type 2 diabetes mellitus is to modulate glucose level by releasing insulin and preserving beta cells. At the same time, it is also modulating glucagon secretion. Okay, so how does it act? It acts, okay, binds to GLP-1 receptor. Okay, the glucagon-like peptide 1, GLP-1, will bind to GLP-1 receptor, increase cyclic AMP, increase calcium levels in beta cells, results in exocytosis of insulin. Okay, so inhibits gastric emptying, decrease food intake, inhibit glucagon secretion, slow the rate of endogenous glucose production. Okay, similarly, with glucose-dependent insulinotropic polypeptide, binds and activates to specific receptor. Okay, so it binds to glucose-dependent insulinotropic polypeptide receptor, increase cyclic AMP, calcium level, and then release insulin. So it involved in fat metabolism in fatty tissues and enhance insulin stimulated incorporation with fatty acids. Okay, so that is how incretin acts. So you can see this is just for interest. They discover the role of incretins okay, in early 19, how do we say that? In early 1900, okay, the role of substance secreted by gut cells stimulates digestive juice of the pancreas, okay, and then finally it is being called as hormone, okay. And then after that they discover extraction of insulin. The term incretin was used in 1932. And the drugs is being used in 2006. So you can see the process is actually taking some time. Okay. And then this one is DPP4. Okay, forget DPP4 inhibitor. So let's talk about DPP4, in which it will regulate incretin. Okay, so the physiologic activity of incretin is limited or regulated by DPP4 enzyme, which rapidly degrades incretin after their release. So this is a good target as well, in which they develop DPP4 inhibitor to block the action of DPP4 and then increase the level of incretin in the blood. Okay? Okay, ni banyak sangat. I think you can read lah. Boleh You can read by yourself. But like I said, you got to know how it acts and how to explain how does the regulation of glucose is actually happening. Okay? And then you got to know what is the characteristic in terms of whether it causes weight gain, how long it will regulate, and then how good is the regulation of glycemic condition of the patient. Okay? And then what is the side effects of the drugs? So at the moment, the side effects of incretin mimetics is quite mild. Okay, nausea, vomiting, diarrhea. Okay, acute pancreatitis. Ada some lesion and some reported carcinoma. Okay. Okay, so that is the summary. Quite banyak, so I'm not going to go through it. So this is DPP-4 inhibitor. So this is the example of DPP-4 inhibitor: sitagliptin, saxagliptin, linagliptin, allogliptin. Okay, so it will block DPP-4 enzyme and increase the level of incretin. Okay. And remember, those two drugs will also have the action on glucagon. So, I think that is about it, about half. Okay. So when the treatment with single oral anti-diabetic agent fail to achieve therapeutic goal, we can actually choose from the list of oral hypoglycemic agents and combine. Okay, and then an early introduction of insulin is considered if there is a presence of weight loss in which it shows that ongoing catabolism, glucose level is not being controlled properly, more than 10% high of HbA1c level. Okay, this is the last drugs of oral hypoglycemic drugs that act on the kidney, and it acts on sodium glucose co-transporter 2 co-transporter 2, okay, SGL2. So what it does, it reduces renal tubular glucose reabsorption. So reduce blood glucose without stimulating insulin release. Okay, so this is the new kids on the block, SGL2 inhibitor. And the drugs that is being approved, canagliflozin, approved by FDA. I forgot to put which year that it has been approved. So probably I'm not sure whether the other three has been approved or not. Okay, so please check. So what it does, it will actually lower the blood glucose level, and the glucose will be removed from the body via the urine. Okay. So jadi you will tengok what is the significance, the advantages, side effects. Since it is quite new, side effects is not that much. There is drug, ini table for drug interaction. Baca ya, please baca. So that is all about oral hypoglycemic agent. I hope it's clear. I know it's a lot. I'm very sorry it's a lot, but since diabetes is quite prevalent, so I think it is very important that you are aware of all the drugs that is available for use clinically. So, 1 jam, nak rehat 5 minit? Okay, I give you 5 minutes.